This is a short video on the brachial plexus and the derivative nerves, muscles, and lesions of the upper extremity. We're going to start with a diagram of the brachial plexus. As you can see, starting on the right side of this diagram, the brachial plexus comes out of the spinal cord at points C5, C6, C7, C8, and T1. These are specifically the roots of the brachial plexus, and they are the ventral rami of the spinal nerves. So when nerves come out of the spinal cord, they come out as roots, which then combine into rami, a ventral and a dorsal rami. The brachial plexus comes from the ventral rami. These ventral rami then kind of combine into trunks. There are three trunks: the superior, the middle, and the inferior trunks of the brachial plexus. You can see that C5 and C6 combine together, C8 and T1 combine together to form trunks. The next part of the brachial plexus are the divisions, which you can see on that diagram there. There's an anterior and there's a posterior division, and you can kind of see how this is an anterior division. This one goes backwards and is a posterior division. This green split of C7 here goes in an anterior direction and in a posterior direction. And similarly, that inferior trunk goes in an anterior direction and in a posterior direction. So you're going to have to imagine a three-dimensional split on this flat screen. Next is the cords. We have medial and lateral cords. So the anterior cords are medial and lateral, and then you have a posterior cord. So this is a posterior cord in the back because it's formed from the posterior divisions of the previous section, and the two anterior cords are medial and lateral. And this makes sense because if you imagine a person in anatomical position, if they have their arm outstretched, this would be closer to the body. This would be farther from the body. So this is the lateral cord, and this down here is the medial cord. And lastly, you have the branches. Now, there are a bunch of branches throughout the brachial plexus up to this point, but then at the end, there are 5 major terminal branches. And those are the musculocutaneous nerve, the axillary nerve, the median nerve, the radial nerve, and the ulnar nerve. And we'll more thoroughly discuss these and where they end up in the next couple slides. It's also important to note that there's a bunch of other nerves that kind of come off the brachial plexus up to this point, and these also innervate important muscles of both the upper extremity and the chest and the back, and we'll talk about all that too. So this is the brachial plexus. This is a good summary slide of the brachial plexus itself. Next, we're going to talk about the derivative nerves, muscles, lesions of the upper extremity that kind of come from or are related to the brachial plexus. So let's make that brachial plexus smaller, and let's work our way around and fill in all the derivatives of all of these nerves listed here. We're going to go counterclockwise here, starting with the dorsal scapular nerve. So these are some arrows. We're going to fill all this in as we go on. So the dorsal scapular nerve pops off of C5, and that innervates the rhomboids and the levator sculptae. These are muscles that are in the back. The levator scapulae, it actually does exactly what its name implies. It raises the scapula, whereas the rhomboids are one of the deeper muscles in the back. The suprascapular nerve innervates the supraspinatus muscle, which is an ADductor of the arm that allows you to raise your arm outwards. The infraspinatus muscle, which allows you to laterally rotate your arm. And lateral rotation is an outward spinning of your arm. These are innervated by C5 and C6. The lateral pectoral nerve, as the name implies, innervates the pecs, the pectoralis major, which is a major ADductor. It allows you to bring your arm closer to your body at the shoulder joint, and also allows you to flex your arm at the shoulder joint. We're going to talk about these 3 subscapular nerves in the middle here. The lower subscapular nerve innervates the subscapularis, the teres major, both of which ABduct, they abduct. They also allow you to extend your arm and to medially rotate your arm. So ABduct, that's kind of elevating your shoulder away from your body. Extension, that's similar. And medial rotation is turning of the hand, or not turning of the arm inwards toward your body. That's a medial rotation. The thoracodorsal nerve, also called the middle subscapular nerve, innervates the lats, the latissimus dorsi, which is another powerful abductor, internal rotator, and arm extender. If you kind of combine all three of these motions, the adduction, the internal rotation, and the arm extension, that's kind of the position of going from anatomic position to putting yourself in handcuffs. That's abduction, internal rotation, and an arm extension. That's all innervated by the thoracodorsal nerve, and the muscle is the latissimus dorsi. The upper subscapular nerve innervates the subscapularis muscle and the teres major. And the functions of these we've already discussed, as they are also innervated by the lower subscapular nerve. And both the lower and the upper subscapular nerve are innervated by the roots C5 and C6. Now, let's talk about the big 5 terminal branches. There's a lot associated with these. We're going to start from the top with the musculocutaneous nerve. Musculocutaneous primarily innervates the flexors of the arm, especially in the anterior compartment of the upper arm. The 3 main muscles here that are flexors are the coracobrachialis, the brachialis, and the biceps. The coracobrachialis is a major ADductor, and this one's unique because the musculocutaneous nerve actually pierces right through the coracobrachialis. The brachialis is the primary flexor of the arm. When you're doing bicep curls, you're working the brachialis muscle, and the biceps muscle is a very powerful supinator muscle. That's kind of like an external, a lateral rotation of the forearm, and that's mediated by the biceps. The musculocutaneous muscle or nerve, after innervating these 3 muscles, then goes on to become the lateral cutaneous nerve of the forearm, and this does sensation on the anterior lateral side of the forearm. So damage to the musculocutaneous nerve not only paralyzes those 3 muscles, but you also lose sensation on the forearm, the lateral anterior side of the forearm. Next is the axillary nerve, which innervates the muscles deltoid, teres minor, and these muscles are essential for abduction. That's raising the arm away from the body. That's the action of the deltoid, and the teres minor is a lateral rotator. The axillary nerve also does a small patch of skin, also does sensation to a small patch of skin on the shoulder. It's called the lateral shoulder arm, upper arm sensation. This nerve also goes on, so as we just said, it does do some sensation on the superior lateral side of the upper arm, and damage to the deltoid nerve or the axillary nerve is notable because it can cause deltoid atrophy. And deltoid atrophy is very evident in the clinic because you lose your nice round shoulder contour. It, of course, also weakens abduction. And one common place that the axillary nerve is damaged is at the surgical neck of the humerus. That's like a thinning of the humerus bone, and that's a common site that the axillary nerve runs down, and it's common for the axillary nerve to be impinged or otherwise impaired there, thus causing deltoid atrophy. The next of the terminal branches is the median nerve. Median nerve does quite a bit in the forearm and in the hand, and we're going to go through it all here. The median nerve first traverses through the cubital fossa before innervating the majority of the forearm flexors. These forearm flexors are located on the anterior side of the forearm. They're separated into 2 layers. There are the superficial forearm flexors and the deep forearm flexors, and the median nerve innervates all of them except for 1.5 of them. And that 1.5 is innervated by the ulnar nerve, which is another terminal branch of the brachial plexus. And we'll discuss that 1.5 with the ulnar nerve. So the forearm flexors innervated by the median nerve are the pronator teres, the flexor carpi radialis, and the palmaris longus, as well as the flexor digitorum superficialis. The flexor digitorum superficialis is notable because it eventually goes down and inserts into the PIPJ joint, PIPJ. This is the proximal interphalangeal joint. And if you look at the tip of your fingers, that's the second joint starting with the tip of your finger. The flexor digitorum superficialis, innervated by the medial nerve, is what's responsible for flexion or bending at that joint. The median nerve then continues through the carpal tunnel to innervate intrinsic hand muscles. A lot of the intrinsic hand muscles are innervated by the ulnar nerve, but the median nerve does do some. Specifically, in the central hand compartment, the median nerve innervates 2 lateral lumbricals. Lumbricals are the worm-like muscles that are in your hand between the metacarpals, and the median nerve does the 2 lateral ones. So that means the ones associated with your second and third digits. It also does sensation on the palmar side of your hand for the first 3 digits and half of the 4th digit, the lateral half of the 4th digit. So these last 2 functions that I have listed here, the innervation of the 2 lateral lumbricals, as well as sensation to the palmar digits on the palmar side of the hand for the first 3.5 digits, those can all be impaired in carpal tunnel syndrome. I'm sure many of you have heard of this. That's when inflammation or another process blocks part of the carpal tunnel, which is a tight tunnel of fibrous tissue that's in the wrist. And when that is blocked or when that is narrowed, you get carpal tunnel syndrome, which is a result of kind of squeezing on the medial nerve and preventing it from doing its functions downstream of the carpal tunnel. Part of the median nerve also breaks off and goes deeper into the forearm. So now we're back behind the carpal tunnel, where a part of the median nerve breaks off and turns into the anterior interosseous nerve. This nerve innervates the deep pronators of the forearm. So we talked about the superficial pronators of the forearm. Those are listed here where the cursor is. The deep pronators of the forearm are the flexor pollicus longus, the pronator quadratus, the flexor digitorum profundus. Now, the flexor digitorum profundus is similar to the flexor digitorum superficialis, but this one inserts into the DIPJ joint. DIPJ is the distal interphalangeal joint. And again, if you look at your the bending of your fingers, this is the distal interphalangeal joint is the first bend of your fingers, and the flexor digitorum profundus is responsible for this flexion at this joint. The anterior interosseous nerve, which is a branch of the median nerve, is responsible for the lateral half of the flexor digitorum profundus. The medial half of the FDP is innervated by the ulnar nerve, and we'll go over that in a second with the ulnar nerve as well. So the anterior interosseous nerve innervates the FDP, the flexor digitorum profundus, for the lateral 2 fingers. That's the fingers 2 and 3. So it bends the DIPJ joint for fingers 2 and 3, whereas the ulnar nerve, as we'll say in a second, bends the DIPJ joint for fingers 4 and 5. Now, a lesion of the medial nerve. No, we got one more branch of the medial nerve first. After the median nerve goes through the carpal tunnel, there's another small branch that kind of goes backwards. It's a recurrent branch of the median nerve, and this innervates the thenar hand compartment. Thenar means thumb, so each of these muscles is associated to movement of the thumb, and the 3 relevant muscles here are the abductor pollicus brevis, the flexor pollicus brevis, and the opponens pollicus. And the opponens pollicus is especially notable because that's responsible for us humans having opposable thumbs, and that's innervated by the recurrent branch of the median nerve. Now, damage to the median nerve can cause a characteristic hand of benediction. And this is when your first three fingers, your thumb, your index, and your middle finger are kind of paralyzed, or they're unable to flex completely when you try to make a fist. So hand of benediction is when you end up bending your fourth and fifth fingers, and it kind of looks like something a religious person would do. The hand of benediction is characteristic of an upper medial nerve damage. Next is the radial nerve. Radial nerve is responsible for many of the extensors, where the median nerve and the musculocutaneous nerve were responsible for many of the flexors. Radial does almost all of the extensors. So in the upper arm, the radial nerve innervates all three heads of the triceps. Triceps is a pretty big muscle in the upper arm, all innervated by the radial nerve. And this comes from the nerve roots C5 to C8. Now, in the forearm, the radial nerve does all of the extensors. This is extensors of both the wrist and the fingers, the digits. And these come from the nerve rootlets C6, C7, and C8, all innervated by the radial nerve again. I'm going to list them here. There's a bunch of them in the posterior compartment of the forearm. So muscles are the extensor carpi radialis longus, the extensor carpi radialis brevis, the extensor carpi ulnaris, the extensor digitorum, the extensor digiti minimi, the extensor indicis, and three muscles that make up what's called the anatomical snuff box, which is that small triangle of fibers that you could see right next to your thumb. Those are the abductor pollicus longus, the extensor pollicus longus, and the extensor pollicus brevis. So that's quite a bunch of extensors of the wrists and the digits, and all innervated by the radial nerve. Radial nerve does more than that too. It also innervates some other muscles that are in the forearm, particularly the brachioradialis, which is kind of halfway between the anterior and posterior compartments of the forearm. This muscle is actually a flexor, as well as the supinator muscle, which does what its name implies. It allows you to supinate, or make a lateral rotation of the forearm. Radial nerve also goes down to do a sensation of the digits. It kind of does the opposite side of the digits as the median nerve. The median nerve did the palmar side of digits 1 to 3.5, whereas the radial nerve does the dorsal side of digits 1 to 3.5. So that's the back of your hand for your thumb, your pointer finger, your middle finger, and half of your ring finger. The thumb side half of your ring finger. Sensation of those parts of the back of your hand are all innervated by the radial nerve. The radial nerve then goes on to do sensation in the forearm and the arm as well. It's called the posterior cutaneous nerve of the arm and the posterior cutaneous nerve of the forearm. And this is essentially sensation on the dorsal side of the arm and the forearm. Now, damage to the radial nerve gives a characteristic wrist drop, and that makes sense because if the radial nerve is the primary extensor of the wrist and the digits, if you have damage to the radial nerve, it can cause your wrist to drop and kind of hang there. Damage to the radial nerve can also cause what's called Saturday night palsy, and that's kind of a result of laying down on your arm in an awkward position on a hard surface for extended periods of time, as if you were passed out drunk on a bench, and that could compress the radial nerve as you sleep and put weight on it. Next up is the last of the terminal branches of the brachial plexus. We're going to talk about the ulnar nerve, and this one also has a bunch of functions, just like the last two. So the ulnar nerve traverses through the cubital tunnel to innervate 1.5 of the forearm flexors, as we alluded to before. As we said earlier, the ulnar nerve innervates the flexor, or half of the flexor digitorum profundus. This was the forearm flexor that went to the DIPJ joint, the distal interphalangeal joint, and that's for flexion of that very far joint in your fingers. That's so the medial half of that muscle is innervated by the ulnar nerve, and that means that the fingers 4 and 5, flexion of fingers 4 and 5, are regulated by that ulnar nerve. The ulnar nerve also does the flexor carpi ulnaris, not to be confused with the extensor carpi ulnaris that my pointer is pointing to now. There are two muscles that have the word ulnar in them on this page. One of them is innervated by the ulnar nerve, and that's the flexor carpi ulnaris. The nerve then goes through the Guyon canal to innervate most of the intrinsic hand muscles. These are muscles that are in your hand that are used for fine movements of your hand. We're going to kind of divide these based on the hand compartment that they're in. So in the hypothenar hand compartment, the ulnar nerve innervates the abductor digiti minimi, the flexor digiti minimi, and the flexor digiti minimi brevis, and the opponens digiti minimi. And these three muscles are pretty much analogous to the three muscles that we talked about in the thenar compartment as innervated by the recurrent branch of the median nerve. These are analogous, but work on the digiti minimi, which is the pinky. The ulnar nerve also does sensation for your pinky and for half of your and for your ring finger. So sensation for digits 3.5 to 5. The ulnar nerve does both sensation on the palmar and the dorsal surface of these fingers. The ulnar nerve then splits off and has a deep branch, which kind of goes deeper into your hand than the rest of the nerve, and this goes to the adductor hand compartment to innervate the adductor pollicis muscle. It also goes into the central hand compartment to innervate the two medial lumbricals. These are the lumbricals associated with fingers 4 and fingers 5, deep in the palm of your hand. And the deep branch of the ulnar nerve also goes into the interosseous hand compartment, and it innervates all of the muscles in the interosseous hand compartment called interossei. And this is both dorsal and palmar interossei, all innervated by the deep branch of the ulnar nerve. Damage to the ulnar nerve can cause what's called an ulnar claw, which is when you try to flex your hand, when you try to make a fist, but because fingers 4 and 5 are innervated by the ulnar nerve, they are paralyzed. And imagine making a fist, but your fingers 4 and 5 only go halfway down, and that's characteristic ulnar claw. We're going to finish up with a couple more smaller branches of the brachial plexus. The median antebrachial cutaneous nerve and the median brachial cutaneous nerve are sensory nerves that go to the medial arm and medial forearm, as their names imply. So they just provide sensation to the medial arm and the medial forearm. The medial pectoral nerve, similar to the lateral pectoral nerve, innervates the pectoralis major and also the pectoralis minor. We talked about the functions of these probably 15 minutes ago. The pectoralis major is an ADductor, so it brings your arm closer to your body. It flexes your arm at the shoulder. And we have a long thoracic nerve that originates from C5 and C6 and goes all the way down through the brachial plexus, down the side of your body to innervate the serratus anterior, which is the boxer muscle. There's a characteristic lesion associated with damage to the long thoracic nerve, and that's a winged scapula. That's worth looking up. It's a scapula that ends up looking like a wing, as the name implies. And this, of course, will prevent you from abducting your arm, which is the function of the serratus anterior. A couple more lesions to go over. If you damage the brachial plexus at the roots C5 and C6, that's called herb palsy or herb Duchenne palsy. This is a characteristic adduction of the arm, internal rotation of the arm, extension of the arm, pronation of the arm, and the hand does a little odd flexion that's known as a waiter's tip hand. It's worth looking up an image of a waiter's tip hand as well. But all of those actions combined together is what's called Erb's palsy or Herb Duchenne's palsy. If you have similar damage to the roots C8 and T1, that's called Klumpke's paralysis, which has an intrinsic hand deformity. You also get paralysis and loss of the fine hand movements, primarily because that ulnar nerve is damaged. And because Klump's paralysis can involve the root T1, you can also get a Horner's syndrome, which is the triad of ptosis, meiosis, and anhydrosis. It's a big association with Klumpke's paralysis. So this has been a lot of brachial nerves, and the derivative nerves, the derivative muscles, and some lesions that are characteristic of damages to these nerves. This is a big slide. I think this is worth studying and knowing for study of the upper extremity. There's another good diagram on Wikipedia as well. I've copied that one here. This is also worth knowing and worth looking at. This one's pretty helpful because it shows you some of the anatomy, shows you some of the muscles, so that could be really helpful to study as well. So this has been a video on brachial plexus and the derivative nerves, muscles, and lesions of the upper extremity. I hope this video was helpful, and thank you for listening.